The 2026 ACC/AHA Dyslipidemia Guidelines dropped in March. 123 pages long, 11 co-signing professional societies, new LDL targets, universal LPA screenings, a brand new risk calculator. On the surface, it reads like a great playbook for cholesterol management in primary care. But before you update your practice based on any of it, I want to show you something every guideline buries in its appendix, and almost nobody talks about at Grand Rounds. This is the first of a 5-video mini-series on the new lipid guidelines. Stay tuned. This document replaces the 2018 blood cholesterol guideline and gets a new name, dyslipidemia, to reflect a broader scope that incorporates triglycerides and lipoprotein A. The writing committee describes this as a comprehensive one-stop shop. Several major new areas. These are going to be the focus of the rest of the series, and we're going to interrogate them. But first, let me tell you how this sausage actually gets made.
There's sausage being made? Where?
Every recommendation in this guideline carries 2 labels. The first is the class of recommendation, or COR, which is identified as a 1, a 2, or a 3. It tells you how strongly the committee endorses it. A COR 1 means it's recommended, COR 2 means it's reasonable, and a COR 3 means don't do it. Those are the grades in the diploma. Then there's the level of evidence, and this is what I think you actually need to pay attention to. Level A means high-quality randomized trials. Level B means more limited data, maybe one trial or observational studies. And level C specifically means expert opinion. What that means in plain language, a group of credentialed people sat around a table, had a conversation, and voted. That is the evidence, not a trial, a vote. Let me give you 2 examples from this document, not edge cases, real recommendations in print right now. First example is for older adults. The guidelines recommend that decisions about stopping lipid therapy should not be based solely on chronologic age. Class of recommendation here is a 1, recommended. Level of evidence, though, is C, expert opinion. Is it wrong? No, it's probably good clinical advice, but it carries the same label as recommendations backed by thousands of patients in blinded trials, and I think that's the problem. Second is the worst nightmare of someone who hates surrogates. It's about measuring lipoprotein A. The guideline recommends evaluating this blood marker for assessment of ASCVD risk. COR of 1, but the level of evidence is a B and R based on non-randomized data. Okay, you're thinking, so it's another marker. At least we know what test to get, right? Wrong. The guidelines themselves state it's difficult to compare results measured by different assays and laboratories. There are efforts to standardize and harmonize LPA measurements, but those are ongoing. Makes you wonder, how can they be so confident in a recommendation if we don't even have a standard to be able to measure it?
If you're confident, I'm confident.
Now let's talk about who was in the room. The 2026 writing committee is genuinely excellent. Preventative cardiologists, lipid specialists, a cardiothoracic surgeon, and interventional cardiologist. These are people who spend their careers managing the most complex, highest risk lipid patients in the country. And that matters because the patients they see every day are not the same patients sitting in your primary care waiting room. Guidelines are written at the extremes. You practice in the middle. That gap doesn't mean you ignore the guideline. It means you apply it with your eyes open. Every time you see a COR of 1 and assume it applies to your borderline risk 52-year-old, ask yourself, was this patient in the trials? Were they talking about her in that room? Over the next 4 episodes, we're pulling this guideline apart, systematically and with a dose of skepticism. Are the LDL targets actually derived from trials that tested those targets, or were they extrapolated from trials that happened to hit a number? Does universal LPA screening make sense when there is currently no approved therapy with outcomes data? Is the prevent calculator actually better than what it replaced, or just better calibrated? And what about bempedoic acid and inclisiran? What hard outcomes data exists, and what does that cost per prevented outcome? This guideline is worth reading. We're just going to read it critically, so stick around. And the Castelli coefficient for the new 2026 ACC/AHA Dyslipidemia Guidelines is a 6 out of 10. The clinical relevance is undeniable. This document will shape how dyslipidemia is managed in primary care for years. The evidence synthesis is rigorous where the evidence exists. But a COR 1 recommendation, backed by expert opinion, is not the same animal as a COR 1 recommendation backed by 3 randomized controlled trials. And this document doesn't always make that distinction. A vote around the table is still a vote. Call it what it is. What would push this score higher, in my opinion? A more transparent presentation of recommendations that rest on trial evidence versus which rest on consensus. Also, basing more recommendation on POOs that's patient-oriented outcomes, and not surrogates. The infrastructure is there. Level of evidence labels exist. The reader just has to know how to look for it. So there you have it. All the headlines are about the guidelines, but it's important not to confuse the rating system for the evidence itself. Until next time, this is Dispenses Written.